Hello and good afternoon, class. My name is Afe Gray. I'm a Psych NP student here at Regis College, and today we'll be discussing a patient named Midge, a 70-year-old woman whose family has become increasingly concerned about her significant change in her cognition, behavior, and ability to care for her great-grandchildren. Midge has no previous psychiatric history, but over the past several months, she's experienced progressive memory problems, declining judgment, visual and auditory hallucinations, and difficulty performing activities of daily living. Her symptoms have now reached the point where they are affecting not only her ability to safely care for her grandchildren, but also her ability to care for herself. For this presentation, I'll focus on two discussion prompts. First, I will discuss a differential diagnosis and the rationale for each. Second, I will explain the evidence-based tools, DSM-5 diagnostic criteria, and medical evaluation that will help establish the correct diagnosis. When evaluating an older adult with new onset psychiatric symptoms, it's important to remember that the underlying cause is often medical or neurocognitive rather than primary psychiatric disorders. Although hallucinations may immediately raise concern for schizophrenia or another psychotic disorder, new psychosis that begins after the age 65 should always prompt a comprehensive medical and neurological evaluation before a psychiatric diagnosis is made. The priority is to determine whether the symptoms are caused by a reversible medical condition or a neurodegenerative disease. My leading diagnosis for Midge is major neurocognitive disorder with Lewy bodies. Several aspects of her presentation strongly support this diagnosis. One of the hallmark features of Lewy body dementia is the early presence of well-formed visual hallucinations. Midge repeatedly reports seeing a person sleeping on the woodpile behind her home and believes this individual intends to harm the children. She also hears this person singing familiar hymns and occasionally sings along. These detailed and recurrent hallucinations are highly characterized as Lewy body dementia and often occur much earlier than they do in other forms of dementia. In addition, Midge demonstrates progressive cognitive decline, impaired attention, poor executive function, and an inability to safely supervise the children under her care. Or wandering outside at night to chase away the imaginary individual and losing track of a young child who's nearly drowned illustrate her significantly declining judgment and safety awareness deterioration. These functional impairments suggest that her illness has progressed beyond mild cognitive impairment and now meets criteria for major neurocognitive disorder. The second differential diagnosis is major neurocognitive disorder due to Alzheimer's disease. Alzheimer's disease remains the most common cause of dementia in older adults and shares many features with Midge's presentation. She has gradually developed worsening memory, impaired problem-solving abilities, difficulty maintaining medications, and inability to complete routine activities of daily living. However, there is one important distinction. In Alzheimer's disease, hallucinations generally appear later in the disease, whereas in Lewy body dementia, these frequently occur early and are often one of the presentation symptoms that are seen in the beginning of the disease. Because Midge's hallucinations are vivid, persistent, and accompanied by relatively early functional decline, Lewy body dementia remains the most likely diagnosis. Another important diagnosis that must always be considered is delirium secondary to an underlying medical condition. Delirium is especially common among older adults and may develop rapidly because of infection, dehydration, electrolyte abnormalities, thyroid dysfunction, uncontrolled hypertension, medication toxicity, or adverse drug interactions. Patients with delirium frequently experience confusion, fluctuating levels of consciousness, disorganized thinking, and hallucinations that may closely resemble dementia. Although Midge's symptoms appear to have developed gradually rather than suddenly, I would safely diagnose dementia without first excluding potentially reversible medical causes. Failure to recognize delirium can delay treatment and significantly increase morbidity and mortality. Additional differential diagnosis of major depressive disorder with psychotic features, sometimes referred to as depressive pseudodementia and late onset schizophrenia spectrum disorder. Depression in older adults often presents differently than it does in younger individuals. Rather than expressing sadness, patients may complain primarily of memory loss, fatigue, decreased motivation, and impaired concentration. In several cases, psychotic symptoms may occur. However, Mitch lacks evidence of persistent depressed mood, anhedonia, or other characteristic symptoms of major depressive disorder. Likewise, late onset schizophrenia is less likely because she has no previous psychiatric history. Her symptoms began late in life and they are accompanied by progressive cognition and functional decline rather than isolated psychosis. Together, these findings make a neurogenetic disorder far more probable than a primary psychiatric illness. After establishing the differential diagnosis, the next step is to complete a thorough evidence based assessment using standardized screening tools. The first tool I would administer is the Montreal Cognitive Assessment, commonly known as MOCA. MOCA is one of the most sensitive cognitive screening instruments for detecting early dementia and mild cognitive impairment. It evaluates several cognitive domains, including memory, attention, language, executive functioning, visual spatial ability, abstraction, delayed recall, and orientation. Because Lewy body dementia often affects executive functioning and visuospatial skills early in the disease process, MoCA provides valuable information that may not be captured by simpler screening instruments. The second assessment I will perform is a confusion assessment method, CAM. Before diagnosing any type of dementia, clinicians must execute delirium assessments because it is frequently reversible. The CAM evaluates four essential features: acute onset, fluctuating mental status, inattention, and disorganized thinking or altered levels of consciousness. If major screening is positive, the priority would immediately shift towards identifying a treatment plan for the underlying cause before concluding that her symptoms are due to neurocognitive disorders. The third useful assessment is the Mini Mental State Exam, the MMSE. Although the MMSE is somewhat less sensitive than the MOCA for detecting early cognitive decline, it remains one of the most widely used cognitive screening tools for both primary care and geriatric psychiatry. The results of this test will always be interpreted alongside the DSM-5-TR diagnostic criteria. According to DSM-5-TR, a diagnosis of major neurocognitive disorder requires evidence of significant decline in one or more cognitive domains, including memory, attention, executive functioning, language, perceptual motor abilities, or social cognition. These deficits must interfere with independent functioning and cannot be better explained by delirium or another psychiatric disorder. Mitch clearly demonstrates impaired executive functioning and judgment. She is unable to consistently supervise your young children, manage medications, or safely perform activities of daily living. Neuroimaging with magnetic resonance imaging or CT should be obtained to evaluate the structural abnormalities such as stroke, chronic subdural hematoma, brain tumors, or pressure hydrocephalus. In conclusion, Mitch's presentation is most consistent with major neurocognitive disorder with Lewy bodies because her early visual hallucinations, progressive cognitive decline, impaired executive functioning, declining ability to perform activities of daily living, and increased safety concerns are prevalent, this requires immediate intervention. Nevertheless, It remains essential to rule out Alzheimer's disease, delirium, depression with psychotic features, and other reversible medical causes before confirming this diagnosis. This case truly highlights the importance of conducting a comprehensive patient-centered assessment that integrates evidence-based screening tools, DSM-5 TR criteria, and a thorough medical examination. Early recognition of neurocognitive disorders allows clinicians to initiate appropriate treatment, improve patient safety, support family and caregivers, and also connect patients with community resources that can significantly improve the quality of life and their overall mental health care. Thank you so much for listening to my presentation today, and have a good evening.